Okay, good afternoon, everyone. My apologies for not having my camera on. I'm having some tech issues with my webcam. I want to welcome you all to our webinar today. It's part of the Infectious Disease Preparedness Learning Community, and we will be discussing the basics of infectious disease outbreak planning. Before we begin, there are a few housekeeping items I would like to go over. First is our mission statement. As many of you are aware, NIHB was created by the tribes, and we advocate on behalf of the tribes in regards to public health, healthcare, and wellness. We provide technical assistance and many other resources and tools. And again, we work on behalf of the tribes. Today, we are going to do a brief welcome and introduction, go over some housekeeping items, discuss some upcoming infectious disease learning communities, as well as Dr. Nichols' presentation. And following that will be a Q&A, which will be facilitated by my colleague, Adriana Marzette. So just a few things to keep in mind. Please keep your microphones and telephones on mute during the presentation. You can use the chat box for any questions or comments. Both Adriana and I will be monitoring the chat box. This webinar is being recorded, and the recording will be available in a few days, as well as the slides. And again, the Q&A will be at the end. However, if Dr. Nichols does choose to ask some questions during her presentation, that is entirely up to her. And I also want to mention at the end of this webinar, you will also receive a link to an evaluation. We ask that you all please take a few moments to complete that. It helps us plan for future webinars and make sure that we're providing the content that you all are looking for. So we will have some upcoming learning communities starting in October. We don't have one next month in September, so please be on the lookout for those announcements. I will now turn it over to Dr. Nichols. Can you please share your screen?
All right. Well, good afternoon, everyone. I am incredibly excited to be with you today and can't wait to talk a little bit more about outbreak investigations. So my name is Megin Nichols, and I work at CDC on a team that investigates multi-state outbreaks of enteric illness. So these are mostly the gut bugs like Salmonella, E. coli, Campylobacter, and others. And when I say multi-state, you might be familiar with some of our work that has been done on foodborne illness investigations such as romaine lettuce. Now, one of the things that's unique about my team is that the outbreaks we investigate are those that are often linked to animal contact. So these are people who might have had exposure to, say, backyard chickens, or maybe pet bearded dragons. Or maybe there were animals in a traveling petting zoo that went from state to state that exposed people to E. coli. So I lead a team of epidemiologists that work on this. But prior to my work at CDC, I actually worked at the New Mexico Department of Health. And although I'm a veterinarian by training, I actually worked on pediatric vaccine preventable disease outbreaks and monitoring of trends in our surveillance data. So outbreak investigation is something I'm very passionate about and have really enjoyed the opportunity to work both at the local and state level, as well as now the work at the national level. So I'm going to go through the outbreak investigations, and some of this is actually going to be participatory. So I'd really love for you to put things in the chat, and I will cue you as to when to do that. So to start out, I thought we would go over what I refer to as the 10 steps of an outbreak investigation. And although this part might seem a little didactic, it's something that I go back to every time we're doing an outbreak investigation, because by having this checklist, it can ensure you don't miss or overlook anything. All right, so what does this look like? So first, you want to prepare to investigate. Then you might want to confirm your diagnosis and make sure that an outbreak actually exists. Next, You want to identify any cases, and we'll talk a little bit about how we identify or define the cases, and then describe them in terms of who is sick in persons, places, times. This is kind of the who, what, where, when, and then it leads to the why of outbreak investigation. Then you're going to want to consider if there's any immediate control measures that you might want to take. Develop some hypotheses about how the disease is spread or about how an event happened. Test those hypotheses, and then refine and implement additional control measures and communicate any findings, which is really a key part of our work at CDC. So one of the things I will note is that although it appears like some of these occur stepwise, it really looks a little bit more like this, where lots of the different parts of our outbreak investigation process are happening all at the same time or simultaneously and may not go in order. So there might be times where we're preparing for the outbreak investigation, but also working to confirm the diagnosis and identify cases all at the same time. So let's walk through these steps a little bit more. So first, prepare to investigate. And this can include a variety of things. So not only is it maybe reading up a little bit about the bug that you suspect might be causing the illness, it might also be gathering any data or information about things that happened previously that had a similar signal or a similar outcome. So for example, if you might see a cluster of respiratory illnesses, are there any materials or guidelines that are available about these respiratory illnesses, including the population that might be affected, if this has happened in the same geographic location before, or any other clues? The next piece is if you're going to investigate, and it might involve field work, or it might involve certain materials that you'd need, such as laboratory testing materials, gloves, other things, make sure that you have all of that prepared and organized before you go out. This might even include something like questionnaire development. Then consider the population that you're working with. As you can imagine, when my team goes out, sometimes we're on a farm. So being prepared often involves wearing shoes that we don't normally wear in our office environment and having some cultural sensitivity for the agriculture community in which we're working, because we know that raising of animals can often be tied to somebody's livelihood and our culture. So making sure that we're aware and keeping that in mind throughout. Next is confirming the diagnosis. So I know this can look a variety of different ways, but sometimes you might not know what is actually causing the illness or outbreak, or you might have a suspicion, or you might have people or animals who are infected with multiple strains of a bacteria or multiple viruses, and you're trying to really narrow down what is causing the illness. Now, some of that can be done through laboratory testing, which is incredibly helpful. Some of it can be done by interviewing people about their signs and symptoms and really gathering that epidemiologic data. And some of it can be done through traceback. So in my work, for example, on foodborne illness, one of the things we might try and do is confirm that not only is the bug that caused the illness isolated from stool in humans, but we might also try testing some of the foods they ate to see if we can pick up that exact same bug in the food and confirm that that's what's causing it. The other thing I will say is that always go through kind of with a gut feeling. So if you're seeing certain signs, symptoms, or reports of illness that aren't necessarily matching up with what you suspect, always have an open mind and consider reevaluating or even retesting at later points in time if needed. When we see new illnesses that are part of multi-state outbreak investigations, we will often go back and make sure that we're comparing the new illnesses to the illnesses that occurred early in the investigation to make sure what we're seeing is similar. Next is determining if an outbreak actually exists. So this might seem a little counterintuitive, but the way the Council of State and Territorial Epidemiologists defines an outbreak is actually two or more unrelated people who have a common exposure that results in the same illness. Now, for me, That might involve two people that both went to a restaurant and happened to both eat the same food, and then were both infected with the exact same genetic strain of something like salmonella. Now, in looking at that, sometimes we might not have an outbreak if, say, the two people, once we investigate, actually were related. Maybe they even were in the same household. And although they both ate the meal at the same restaurant, it was actually something that was circulating in their household. So that's what we mean by determining the existence of the outbreak. Sometimes we see what we call clusters. So in the foodborne realm, we might see people who have the exact same genetic illness and pop up in different geographic locations over time, but there's really no single common exposure that links them together. So that might just be that there's a certain baseline of illnesses that are happening over time, but they're not really grouping in time or space and not having a common exposure. And therefore, there might not be an outbreak there to investigate. Now, once you do confirm that there's an outbreak, the next step is to identify and count cases. And laboratory testing can be incredibly helpful with this, but sometimes you might also identify people who were sick, but didn't have an opportunity to be tested. And that's a time where you can develop what we call a case definition. So this is kind of the who, what, where, when, and why. So this might be infection with a particular strain of salmonella in the month of December, who attended a particular event. That could be one way to identify or classify an ill person into what we call an event, meaning a case. Now, once we come up with that definition, we might need to revise or revisit that. And it can be helpful because sometimes, like I said, we might include laboratory testing as part of that definition, but we might find a whole group of people that didn't have an opportunity to be tested. Now, this is relatively common if we have outbreaks of respiratory disease or even something like Campylobacter. So with Campylobacter and most of our enteric or gut bugs and foodborne illness, what we tend to rely on is culture-based testing. So we take samples, usually fecal samples from people who are sick. Those are tested, and we actually try and isolate or grow the salmonella bug or Campylobacter bug or enteric bug out of the feces, and then do some genetic testing on that to determine what strain it is. But sometimes we might have people who report diarrheal illness who also had that exposure, and maybe they even reside in the same household or attended the same event as a person who got sick, but they didn't have the opportunity to be tested, and now they're well. Well, we might consider that as a suspect case or even a probable case, but not necessarily a confirmed case for whom we have laboratory testing. So looking at those definitions can be pretty critical in determining that. In other outbreaks, we've also seen instances where one person might say attend an event and get sick, and then come home and people inside their household subsequently develop illness after that initial person, but they didn't attend the event. In that case, we might classify that as a secondary case, meaning that the people in the household got sick from the initial person because they didn't attend the event, but maybe there were lapses in some hand hygiene. Maybe the ill person was preparing food while they were ill and didn't have great hand hygiene, and subsequently other people in the household became sick. So this can also be really helpful as you move through time to make sure you're categorizing or classifying the number of events or the number of cases that happen over time. And this can help you not only to determine where you are in the stage of the outbreak, but also when an outbreak is over, because ideally, once you investigate, you want to see the case count go down. So let's talk a little bit more about describing the outbreak in terms of person, place, and time. So once you develop your case definition, there are some really, really great ways to visualize this and try and look at what you're working with. Now, these are two examples from some of our multi-state foodborne illness investigations, where you can see that in the upper right hand, what I have is an epidemiologic curve. So looking at this, what I have across the bottom, or the x-axis, is the date of illness onset, or the date that the person became sick. And then on the y-axis, or the vertical side, I have the number of cases, or the number of ill people in this instance, who became sick on that date. So you can see that this outbreak appears to have started in May, where we only have maybe one case in May, one case in June, and then something happened where we had quite a few cases, around 9 cases, happen in the month of July. And then this is a good way to also look at some of your interventions, because maybe we put something into place in November, December, maybe it was a recall of a particular food item so that it was no longer on the shelf. And subsequently, you might see cases decline. Now, this is actually a really interesting one because this is our backyard poultry season, where you can see that in the spring, people often go to stores and purchase poultry for backyards and keeping them for eggs or sometimes as pets. And so we start to see the number of people who get sick, and this was one very particular strain that the backyard poultry were carrying. It makes people sick. We see an increase in the number of people, and then we see a decline towards the end of the year, mostly because people no longer are buying backyard poultry in the winter. But come the following year, we again see more people who buy backyard poultry, unfortunately, subsequently become ill with salmonella, and we see the outbreak recur. Another great way to visualize illnesses is by mapping them and looking at any geographic clustering. So this map actually is from one of our foodborne illness outbreaks, where we started to see that most of the people who got sick were in the upper Midwest, kind of towards the New England states. And so it led us to hypothesize that there might have been a product, or in this case, a food product, that was predominantly distributed around that area with additional distribution to other states. But it really helped us hone in on products that might have a headquarters or a distribution center, or even a retail grocery chain, for example, that sells products in a particular area. So that can give you clues too. You can also map this by things that are much more granular. So you can map by county, you can map by street location, you can map by a variety of things. And so these are some examples of ways to just describe that data. Now, once you have this information, sometimes there's intermediate control measures that you might be able to implement. So I talked a little bit about how my team investigates animal contact outbreaks. Well, in this instance, let's say that we find out that all of the people who got sick happened to attend a particular animal show event. Well, one of the things we might proceed in implementing is going to the show and actually talking about hand washing and implementing that right away, even before we have additional information. Other control measures might include staying at home, avoiding close contact with people who are sick, mask wearing, hand washing, etc. Some of these might be recognizable to many of you on the call today, as I know many of us are involved in these as we speak. So next, once you have this information, it can really help you to develop some hypotheses about what is potentially causing the illness outbreak. So you might have your diagnosis, you might know a little bit about the bug, you might have done some historic research to try and find out about outbreaks that have previously occurred. You've defined your cases, so you know who it is that you're investigating who got ill. And now you have some hypotheses. So you might think it's a particular food product, or you might think it's attendance at a particular event. It could also be a particular healthcare acquired infection from seeking healthcare at a particular time and exposure to something that happened. Maybe it's a procedure that was done, some type of medical procedure. So in that instance, you want to develop these hypotheses, and then you want to go ahead and test them. So in developing the hypothesis, some things that are very helpful to consider are demographics. Age, sex, race, and ethnicity can be very helpful in doing that. So one of the things that we might see in our reports is sometimes we'll see what we call a healthy eater signal. So there's an epi curve of one of those instances here, both at the top and then at the bottom, where we started to see among people who were sick in one of our foodborne outbreaks, people were reporting very, very healthy eating. Lots of salads, lots of healthful fruits and vegetables, lots of health smoothies, protein shakes. reporting a lot of fitness activities. So that really led us to think about, what could it be that might be linked to this? And lo and behold, we noticed that a lot of people were having or consuming a protein powder or a smoothie that included lots of chia seed powder. Looking at the geography can be really helpful. So are people located in a particular area? The shape of your epidemic curve can also be helpful. So the difference here between sprouts and chia is that sprouts are a perishable item. They might be on the shelf or be in a particular restaurant or grocery store only for a short amount of time, and then they spoil and they're removed. So here's what you see. It's more of a point source outbreak where the epidemiologic curve increases and then it decreases, often because the product is gone. Now in the chia seed powder example, that is more propagated. So it occurs, the number of people who got sick occurs over a long period of time. That indicated to us that it was more of a shelf stable product. So a product that might be on the shelf for a long time in people's homes and cause illness over a greater period of time. The pathogen can also be really helpful to consider. Are there potential signs of illness? Is illness really severe? Are you seeing more or less hospitalization? Are you seeing any antibiotic resistance that's occurring? That can help give you some clues. And then exposure frequencies. So in interviewing people, asking them all about, so you've got some hypotheses about what it could potentially be. You can believe when we were looking at this particular outbreak, when it involved chia seed powder, we were asking a lot of questions about everything the people could have eaten. And then we were comparing what percentage of people who got sick ate lettuce, what percentage of people who got sick ate tomatoes. And lo and behold, one of the things that started to emerge were these smoothies. And when we dove in a little bit deeper, we identified the chia seed powder as one of the main ingredients across people who consumed the smoothies. I see some great questions. So I just saw, do you use a standard questionnaire in outbreaks to gather information to form the hypothesis? Absolutely. So as you can imagine, these outbreaks happen sometimes when you don't expect them. And having a repository of some questionnaires that we've used in the past can be really, really helpful. Now, I will say a lot of local, state, and CDC and other health agencies actually do have some questionnaires that they maintain. And I know when I was at the state health department, I had a very low threshold for sometimes calling colleagues in a neighboring state and saying, hey, have you ever encountered a foodborne outbreak associated with a potluck event before? Do you have a questionnaire that I might borrow as a template? We also have some really great resources, and I can send this along after the talk, with our integrated food safety centers of excellence. And some of them on their websites actually have some questionnaires that you can download and you can edit and you can manipulate or change based on the outbreak. Now, I will say, one of the things that happens with our foodborne outbreak investigations is that sometimes we need to collect standardized information across a lot of different states. And every state has a need to collect some information that's different based on their population. But somehow we still need, when we look across all the data, to have a common core set of data elements. And that's something that we worked with groups like the Council of State and Territorial Epidemiologists, or CSTE, on developing what those core data elements are, so that I know, regardless of what state I'm calling to ask for data or information, all of them have taken a food history for the 7 days that the people, 7 days prior to when the people got sick. They often ask about any contact with animals, and then they'll often also ask about water exposure, both drinking water and recreational water exposure, along with some others. So that can also really, really be helpful. In the event we have a multi-state outbreak and we're having trouble figuring out what it is, we'll use the National Hypothesis Generating Questionnaire. So this is what we call our NHGQ at CDC. Now, I will say we don't ever deploy that lightly because it can take a long time to administer all of those questions, but it goes into really, really great depth about any food people have eaten, including, for example, lots of questions about, say, chicken. Did you eat chicken in your home? Did you eat chicken in a restaurant? Was it a rotisserie chicken? Was it chicken breasts? Was it chicken with the skin on? Was it chicken nuggets? And on and on. So you can imagine that in instances where we know it's a foodborne exposure or we don't exactly know what it is and we need to dive in, we can actually deploy one of those standard questionnaires. Excellent. And a lot of the examples I'm going to use today, I see a question about COVID, are transferable to COVID-related clusters or outbreaks, and exploring those a little bit further, but we won't be necessarily referencing COVID-19. So we tried to make it broad enough that it would apply to a variety of different things. All right, so let's talk a little bit, once you've developed your hypothesis, let's talk about testing it. So there are a couple different ways, or a couple different buckets where I look at testing the hypothesis. First is looking at the epidemiologic information. So not only who got sick and the demographics and some of the information I mentioned previously, but comparing those across the different states, different localities, different counties, and looking also at exposures. Was there a particular place everybody went, an event that they attended, an animal they had contact with? Then we look at some of the laboratory testing, so some of the environment and our microbiologic testing. So can we actually test the food product or the animal and see if the strain can be found there? And then the traceback data. So did the person buy something from the grocery store, attend the event? Were they in the hospital at a particular point in time that corresponded to this? And can I link that to other patients who had that common event and trace them back to that source? So in testing the hypothesis, I talked a little bit about this, but we might go ahead and interview patients, collect other records such as shopping records, go through restaurant menus or receipts, analyze all that data, and then sometimes we want to compare that data to the data of healthy people. So if there were some people who attended the event and subsequently did not become ill, what is different between those people and people who, say, did become ill or were subsequently experiencing an adverse outcome, such as a hospitalization or death? I think that's something that we're very familiar with right now in evaluating things like vaccination status. Looking at who's responsible for our multi-state outbreaks, CDC often will develop some of the questionnaires in conjunction with partners. State, local, or health departments interview the patients and actually might collect some samples. And then all of that data from the variety of state or other localities gets uploaded to CDC and it's analyzed. So that's how we do it here. And then at that point with traceback, what is done? So looking at these common exposures, we might look at what animal products or what foods could we document that the patients had exposure to? Are they available for testing? Are there receipts or shopper card information? This might be another one when we're looking at a multi-state food illness outbreak or even a local outbreak. Is there a shopper card record, something that might help us identify what they purchased, especially if it was a while ago and they don't remember? Are there any invoices or other pieces of information that might help us to look at where something was purchased? I know in some healthcare acquired investigations where there might be a medical device, looking at the manufacturer cleaning and sanitation recommendations can be something that is helpful. And then who does this? Oftentimes state or local health departments and or regulatory agencies might be involved. So with a multi-state foodborne illness investigation, we might work with a partner like FDA or even USDA. So FDA, the Food and Drug Administration, or USDA, the US Department of Agriculture, to learn to hand over records to them and help them to investigate a little bit more about what happened and why it happened. And this might involve working with grocery stores or retailers, or even going back to farms and learning a little bit more about how food contamination occurred. Now, looking at the microbiologic side or the laboratory testing, this can be really, really helpful in foodborne investigations, in respiratory disease investigations, kind of in all of the above. So in my work, what we often do is product sampling. So we might sample from the person or the animal and look to see if there's any clues about where that contamination came from. So if it's a food product we suspect, we might actually do some testing of the food. There might also be sampling at farms, in manufacturing plants, in distribution centers, or any point along the chain where that food went. And then we also might look at some of the historic data. So do we have any isolates in our database from lettuce or from chicken that occurred long ago in the past that might clue us in to what's causing it today. Oftentimes, our state and local health departments and agriculture departments might do some of the sampling of either food or animal products, along with our federal partners at FDA, USDA, and even sometimes at CDC. Now, looking at the data, here's where we're actually trying to interpret it. So sometimes linking a company to a food or animal product, it's never something that's taken lightly, because we know on the other end of that, although we have a lot of ill people, there's a high risk if we get it wrong. There's a high reward if we get it right. So this is something that we want to make sure that we have all of the evidence evaluated together to really explore and ensure that we have the right, we're implicating the right vehicle or the right product and not getting that wrong. Oh, this is an excellent question that I'll go ahead and address now. I'm curious about your thoughts on what makes something rise to the definition of an outbreak when it's already endemic in a given population. This is such a great question because it's something that we encounter on a daily basis. Oftentimes in the population, there's always a background rate of salmonella. So every day people are getting salmonella. So how do we pick out of that what exactly is causing an outbreak versus what's something that is just potentially endemic because of, say, it's in the environment or something that's happening over time? And that's where our surveillance really comes in handy, because we try and look over time at what that baseline rate in any given geography or any given time frame might actually be expected. And then are there times where if we're graphing it, we see something increase above what is expected? Oftentimes that is our threshold. Now, it can be a little challenging because you have to know what that baseline is at any given point in time, using your historic data to look at that. Now, I also will say, when I was in New Mexico, many of our public health nurses had a gut feeling about things, and they'd say, they'd call and they'd say, you know, I've noticed something. I never get calls from the school nurses about diarrhea. And today I got 4 calls. So that can also be an instance where you're picking up something that is above baseline and might signify the start of an outbreak. Now, that's why one of those steps is to confirm the existence of an outbreak, because you might investigate and you might find out that's not actually the case. So implementing and evaluating your control measures. So I know a lot of times there's a lot of focus, especially on the national level, with the implementation of the control measures. Did we get a recall? Was the product removed off the shelf? Can people receive a vaccine? What is the potential measure that we can take to stop people from becoming ill and stop the outbreak? However, the thing that I wanted to make sure that I included today is about evaluating those control measures, because it's something that we always need to do to determine whether or not our implementation of a control measure was actually effective in stopping the illness or stopping the outbreak. And that's something that might need to happen over time. And then communicating these findings. So many of you might have visited the CDC website, where we have information about some of our outbreak investigations and things that cause that. Now, I will say I am so incredibly grateful that we have communication specialists on our team who are working with us all along the points of an outbreak to basically see what we're seeing at the same time and help us decide at what point do we communicate about this. So when we communicate a finding, we want it to be actionable, right? We don't want to communicate something that just says, well, here's what we're seeing. We want to tell people what they can actually do about that and how they can potentially protect their health. So we want to make sure that it's actionable. We also want to make sure that what we communicate is specific. And this can be really challenging because what might be specific to one audience isn't always specific to another audience. So sometimes we conduct work like focus groups to help tailor our message. All right. So next, one of the things I wanted to do was actually walk through an outbreak investigation. And this was an outbreak of human E. coli 0157 infections that were linked to agritourism at a goat dairy farm in Connecticut. So let's talk a little bit about E. coli. So the first step of our outbreaks is prepare. So what do we know? We know that it can be transmitted through fecal oral transmission. Animals like cattle, sheep, and goats are reservoirs, meaning they have it in their intestine or in their gut, but they can still appear healthy and clean. It doesn't necessarily make them sick. We also know that E. coli can survive in the environment for a very long time. Some of the literature indicates up to 42 weeks. And we know it can cause a significant amount of illness and death. And we can see some pretty severe illnesses. So complications from things like hemolytic uremic syndrome. We also know that it can predominantly affect children and cause that severe illness in children. And in this case, guess who often goes to petting zoos? We know that the incubation period is around 2 to 10 days, which is really helpful. In the event you start to see illnesses, you might be able to say, okay, here's when we expect to see additional illnesses if all of these people attended the agritourism event on the same day. In terms of signs and symptoms, we see abdominal cramps, diarrhea, which can be bloody, and vomiting. And then I mentioned the hemolytic uremic syndrome. About 5 to 10 people can develop that. And that basically really adversely impacts the kidneys, and children are at higher risk. So when we got the call about this, we found out that on March 24th, the Connecticut Department of Health had seen 7 ill people reported to them. 2 of them had developed HUS, and the hospital records indicated that they had visited Farm X. So big kudos to the healthcare providers who took a really thorough history in this instance and were able to detect that this was indeed the case, that they had this common exposure. So we implemented some immediate control measures because there were 7 illnesses already, which was above what Connecticut would have expected to receive on any given day. And because the illnesses were so severe, the farm was actually closed to the public by the local health officer. They went ahead and they said, we're not going to allow anyone else on the farm at this time. Then there was some communication that was initiated. So on March 24th, the Department of Public Health issued a press release asking the public to contact them if they had attended the event at the farm and if they were experiencing any signs or symptoms of illness, including those associated with E. coli. So specifically diarrhea, nausea, vomiting, and this press release was sent not only to the general public, but there was also a focus in communicating this to healthcare providers through a health alert. So next, we wanted to go through and count and describe cases, which we hadn't done yet, but we have done some immediate control measures and we've communicated some findings. But now we need to generate and test some of our hypotheses because we expected it might have been E. coli. We know it was goats, we know they carry it. We'd seen hemolytic uremic syndrome in the children and we were thinking, okay, there's potentially something going on at this venue, and then figure out what other control measures we might be able to implement. All right, now comes some participation from the audience. I wanted to know if you were in the field and on this farm with me investigating, what type of questions would you ask during the interview of patients? What would you want to know to help you with your hypothesis generation? Go ahead and put that in the chat. Ah, excellent. Which animals the guests petted? What their role is? Excellent. Did any of them happen to work on the farm? Was any hand hygiene available after petting the animals? Excellent. Yes, all of those things. That would be really, really key in not only potentially identifying what the exposure was, but also were there any things that could be implemented to try and prevent illness, or were there any things that were not implemented that were linked to illness? And then in conducting laboratory testing, we did go ahead and we tested both, of course, the people's samples were tested, and they did pulsed field gel electrophoresis, which is some basically DNA fingerprinting of that bacteria. And it was whole genome sequence. So we had the genetic sequence of the bacteria that affected the people, and we could compare it to other people who got sick. And we did some animal testing to see if we could pick up that exact same genetic strain of E. coli in the poop from the animals. And here was our case definition. So we said laboratory confirmed E. coli 0157 infection with one of the outbreak strains. And again, we defined that based on our laboratory technique and our whole genome sequencing, or physician diagnosed hemolytic uremic syndrome and diarrheal illness in a person who had visited Farm X within 10 days of symptom onset, or they had an epi link to Farm X. So they basically had a close contact with somebody who visited Farm X, or maybe they had contact with one of the goats that was sold from Farm X. In this instance, when we described the cases, we saw 46 total cases. 11 of those were hospitalized, 3 had hemolytic uremic syndrome, and 0 died. The median age was 5 years old, and then 23 of these patients were less than 5 years. So pretty much half the patients, and 21 of them were female. When we described the cases by illness onset, what we saw is that quite a few people got sick early on in the investigation. And there were a couple of different events that were actually held in March of 2016, prior to when we saw the big uptick in the number of illnesses reported. Now, you might ask, why did we see illnesses all the way into April and even into May? Anyone know? What might have happened there? Go ahead and put it in the chat. And the farm was closed on March 24th. Yep, we closed the farm. So we thought we shouldn't see, if the incubation period is up to 10 days, then we probably only would see cases into early April, right? Ah, yes, someone got it. Spreading infection to one another. Absolutely, secondary infection was very key. And that made us realize that we needed to do additional communication, especially with parents of young children, because a lot of times we are seeing the young children get sick, and parents who were changing diapers or helping with toileting were subsequently getting sick, even though they had initially not gone to the farm or been ill. We also saw some kids who attended daycares and had diarrheal illness, and then subsequently other kids in the daycare setting got sick. So we had to do some additional communication there. So here I've marked out the farm visits that happened March 5th through 24th. All right, now looking at hypotheses, we also found out that on a visit to the farm, that the farm had 120 milking goats, and they produced over 500 gallons of milk per week, and they sold the cheeses, soaps, and caramels at a farm on a little store on the farm, and they also sold the goats, and they were licensed to sell raw milk. Any other hypothesis happen to occur now once I tell you that they were selling food? And go ahead and put that in the chat if you have any additional ideas about what this could have been. Contamination. Yes, good question. So that was something, yes, they bought food and they brought it home, and maybe that could account for some of the illness spread in households. So we looked at that too. And the Department of Agriculture in Connecticut actually tested the milk and actually tested some of the cheeses and did not find E. coli in them. And we also found out that they weren't selling raw milk at that time. They were selling only pasteurized milk, because we also know that raw milk, when it's consumed, if you think about this on a goat dairy, there's a high potential for fecal material to actually get into the milk. And if it's not pasteurized to kill the germs, those fecal bugs that get into the milk can really multiply, and we can see illnesses linked to consuming raw milk. Now, we looked at the layout of the farm, and it had been pretty rainy. And so one of the things we noticed is that there was a big compost pile where a lot of manure was, and a lot of the kids had reported climbing on the manure pile. We looked at the milking parlor, a little bit around the farm store, and the parking. And then we also looked at social media clues, because one of the things we noticed was what we wanted to know more about was what kind of contact had people had. And when we were doing these interviews, some of the patients said, oh, well, let me show you my social media account because I took lots of pictures of our interactions with the goat that day. So they had this open house where they had up to 500 daily visitors. They had also held a goat keeping class. And you can see here that people were really allowed to interact very closely with the goat kids. And they're very cute. So I can see why that would be very tempting. But having grown up in a rural agriculture environment myself, one of the things I know is never to lay down in the hay, because anytime there's hay on the floor, there's probably going to be some poop. Now, we asked a little bit about whether or not there were any recent changes to their operations, and we did not. What we learned was that the bedding in the kid barn was not routinely changed. So new bedding was piled on top of the old bedding, and if people were laying in that, that was certainly a concern. And then because it was a farm in which there were a lot of birthing events or birthing classes for the does and the kids, there were often bedding and or birthing byproducts that were raked into some of the pits and then added to the compost pile. So that added another layer of communication for us, because we thought, well, there's other pathogens or other bugs that we're not necessarily seeing in this outbreak, but could be a problem in the event that they occurred, because people can get other diseases from birthing byproducts. So this is the team that was out in the field. They collected lots of samples of bedding, fresh stool, and from the compost pile. They also looked at whether or not people had visited different, when people visited different barns, they looked to see in those barns, what did those look like? And so you can see a picture here in the lower right corner of the compost pile and some of the barns. I mentioned collecting some of the animal specimens along with the food specimens. And then in looking at our test results, and this is kind of our cartoon depiction, this is the kid barn. So this is where the baby goats were kept. And you can see there in red where the E. coli outbreak strain was isolated. So it was in quite a few places in the barn. So 3 pooled samples from the doe barn actually tested positive for the outbreak strain. The food specimens were negative, and there were no issues with the pasteurization equipment or the processes there. So I wanted to ask you, and go ahead and put it in the chat, knowing that we found positive outbreak strains in the doe barn and in the kid barn, are there any potential communication things that you would add to this, not necessarily to the public or to patients, but what would you tell the farm owner in this instance? Do they sell kids to other farms? Excellent. Clean the pens, improving cleaning procedures, absolutely. Better sanitation. Now, it's interesting to me because now I work on enteric zoonoses. I used to work on the pediatric infectious disease, including a lot of respiratory disease outbreaks. And it's very interesting to me because this is always a common denominator: hand washing and sanitation. Now, I will share some of the results with you of our whole genome sequencing, but you'll see here I've color-coded the animal, environment, and human isolates, all to see it, and all were sequenced. And what we found is they were within 0 to 6 single nucleotide polymorphisms. Now, if you remember back to your biology or biochemistry, that includes your base pairs, the things that our DNA is made up of. And when we looked at that within the DNA sequences, and some of these bacteria have millions of these base pairs, it differed by 0 to 6, which means that they're highly related, likely the same strain. All right. So looking at some of the evidence, we saw that there was epidemiologic and lab evidence for an outbreak of E. coli 0157 infections with exposure to goats and widespread contamination in the environment. We also found out there were no hand washing facilities. And when you have up to 500 visitors on your farm in any given day, that can be really tough to provide enough hand sanitizer. Now, I will also say that bottles of hand sanitizer with that many people, you've got to really, really have a lot. And in this instance, it was not effective in preventing the large outbreak. Now we know that agritourism is really growing in popularity, and working on farms is great because it can connect farms and agriculture with the community. So we don't necessarily want to tell people never to go on a farm, but what we do want to do is try and prevent and minimize any disease or injury risk through some really basic standard precautions. And there's a really great document called the Compendium of Measures to Prevent Diseases Associated with Animals in Public Settings. So if you or anyone you know happens to have an agritourism venue where they bring people onto their farm so they can learn more about agriculture, this might be a good document to pass along because it's got some really simple things people can do to protect themselves and their health, and also the health of their animals. So in this instance, we did a lot of communicating. So we gave the farm owner the compendium that I mentioned. We also provided some education and training material, and really encouraged that there was more oversight of the animal contact venues. So someone there to make sure people wash their hands, use the hand sanitizer, or didn't lay down in the hay. So you can see some of that here on one of our signs. And all of this is available on the CDC website. We actually have a website called Healthy Pets, Healthy People, and you can go on and find some of these resources that you can print and adapt and use. Now, this was really a unique and innovative thing because sometimes on farms, you might not have access to running water in all the places you need it. So this was great. We had some students who came up with an innovative way to create a hand washing station. You can see it there in blue, paper towels, bungee corded to the top, some soap and some water. We only had to make sure the nozzle stayed really, really clean. All right, so with that, I will go ahead and stop sharing my screen. And I will take any questions. I'm happy to answer any questions about outbreak investigation. I put my email address here. So if there's additional resources or information that are not specific to some of the things I've covered today, I'd be happy to try and address those or route you to colleagues who might be able to address those. And I'll pause and see if there's any additional questions.
Hi, Dr. Nichols. Thank you very much for your presentation. I have two questions.
All right.
So my first question is, can you provide an example of what these steps look like in regards to COVID-19 or respiratory illness?
Absolutely. So they often look very similar, with the exception of some of the things I mentioned around product testing. Now, you'll also recall, though, early on in transmission of COVID, one of my roles at CDC was actually to work on some of the questions we got around spread and food. So could it be spread via food? Especially if there were questions about packaging, what did that look like? And so some of the work that we did was to look at that hypothesis. So we had a hypothesis about and a question about whether or not it could be spread on those things, and then actually testing that and seeing, are we seeing any outbreaks of illnesses or clusters or people who didn't have exposure to other ill people, but solely had exposure to packaging? And then we also looked at a lot of the data coming out to say, are there any studies where they're swabbing packaging and they're finding it? And fortunately, we did not find that to be the case, and we were able to communicate that in this instance, food was not a source of transmission for COVID-19. Now, respiratory illnesses and outbreaks in general can be pretty tough because the spread can be really hard to monitor, but I really think asking some of those basic questions about where were you, who were you around, and even having people look at calendars, were you around anyone that was sick, can be really, really critical to investigating any of those outbreaks. And then again, looking at some of the interventions and control measures and evaluating those.
And we have a question from the chat box. The statement is, the timeliness of response to an outbreak seems so vital. Here's the question. Any suggestions on speeding this up?
You know, that is an excellent question. And I would say training your team ahead of time is one of the most critical things that we can possibly do. So oftentimes, I know many of us wear so many hats in our jobs, and it can be incredibly overwhelming. But one of the things that I have in my team now, and that we also had in New Mexico, was a group of people that were trained in different roles and types of activities during outbreak investigations. So we had one person who was great at developing questionnaires and actually getting the data from the questionnaire into a database and analyzing it. We also had some public health nurses who were really, really good at drawing blood and doing that when it was needed, or talking to people about collecting stool specimens. So anything that you can do to train and prepare ahead of time allows you to hit the ground running, because you are absolutely right. Timing is very, very critical. Now, that's not to be said that in the event that you are you don't have that luxury of training ahead of time, you can always do just-in-time training. There's some great resources that are available, including on the CDC website. And I think that that's definitely key, but you can always play catch up when needed. I just like to have this checklist to make sure I didn't forget anyone or any steps.
Correct. So just as a follow-up, would you recommend incorporating these steps in emergency preparedness plans?
Mm-hmm. I do. I think anytime that you are going to respond to an outbreak event, and I know that an outbreak is just one example of an emergency, but I'd say that having a process or a checklist that you have that is already pre-developed that you can reach for and pull off the shelf can sometimes be incredibly helpful in making sure that you're addressing things quickly, and you don't have to kind of make things up or figure it out as you're going along. So I'd say that for this, yes, the 10 steps of an outbreak investigation are critical when you know that's kind of the emergency that you're facing, but any other checklist that you can develop or maintain, maybe it's for a natural disaster that you're encountering in your area. Maybe it is for a respiratory disease outbreak or a pandemic. Looking at those plans ahead of time can be really key.
So there's an attendee made this statement. I'm curious about your thoughts on what makes something rise to the definition of an outbreak when it is already endemic in a given population. Based off of your response that you just gave, would you say that that definition may differ by communities, because each community may have different patterns or frequency of whatever the outbreak is?
Mm-hmm. Absolutely, absolutely. And I think that also applies to some of the emergency response activities, right? In New Mexico, we never had a hurricane, right? It was a desert. However, we were very prone to having wildfires. So knowing about what is the baseline of respiratory disease that we might expect from smoke inhalation, what is the baseline level of ER visits linked to asthma events, and did those increase during fire season? Anytime that you have something like that you might be able to expect or prepare for in your community, trying to figure out what that baseline is, or soliciting that input sometimes from the members of the community or from the healthcare personnel can be incredibly helpful in determining when you might be seeing an uptick or an increase.
Do we have any more questions from any participants today? You may unmute yourself if you would like to speak. And you have a lot of praise, Dr. Nichols. They're saying thank you.
Well, thank you all. This has been a really incredible opportunity, and thank you all for the work that you are doing day in and day out. I know as health and public health professionals and scientists and others working in these fields, these times can be very challenging. So thank you for all your work and for the opportunity to meet with you today. And please don't hesitate to reach out to me if I can ever be of assistance.
And as Courtney stated earlier, beginning of this webinar, the recording and slides will be available following this presentation in a few days. So check our website and we will try to send out an email, maybe possibly Tuesday, Wednesday of next week.
Also a reminder, please complete the evaluation. It only takes about 5 minutes or so. Thank you. And before everybody hops off, I just want to thank you again for joining us this afternoon. And as Dree mentioned, be on the lookout for the recording and slides.